The goals of therapies are summarized here and divided into essential thrombocythemia, polycythemia vera on the left, and then myelofibrosis on the right, because basically the diseases are addressed per the needs. However, essential thrombocythemia and polycythemia patients have much more significant risk of clots, thrombosis, or bleedings, especially at the earlier disease onset and throughout the first 1 or 2 decades. Therefore, there is a thrombotic risk strategy that prevents the evolution of next clot in both of these disease categories. And I've highlighted the patients that have so-called high-risk disease. So patients with ET being over the age of 60 or having history of thrombosis, or patients with polycythemia vera with similar categories would need cytoreductive therapy or some kind of approach to control these risks and hopefully also achieve control of other disease presentations. Patients that would not fit into these categories would be so-called low risk, and these patients would need therapies only under certain circumstances, which I like to call as uncontrolled disease presentations. So people being bothered by significant symptoms, spleens, too frequent phlebotomies, experiencing complications, bleeding issues, and so forth, should need the disease reassessed repeatedly and then addressed with various therapies we could offer. On the right side are myelofibrosis presentation that are very broad spectrum, where a lot of these patients could be only observed if the disease is presenting in the early stages, and then the therapy is directed to current needs, which at the more advanced stage usually involve increased splenomegaly or increased symptom burden. And then as the disease progresses or presents more in so-called cytopenic phenotype, that means patients will come with a low platelets or low red cells to certainly less degree extent, but also possible neutrophils, then would be addressed or treated with only currently approved therapies for myelofibrosis, which are JAK inhibitors. So drugs that are oral, that are intended to block the JAK-STAT pathway, not particularly JAK mutation, the pathway. Therefore, it does work irrespectively of the drivers. As I mentioned, the most common JAK2 calreticulin, but there is also a percentage of people we don't know what the drivers are. So JAK inhibitors would be used irrespectively of the molecular misstep. There are 4 that are listed here and summarized based on the line of the approval: ruxolitinib, fedratinib, pacritinib, and momelotinib. They are all intended to improve symptoms and spleen to certain degrees. Ruxolitinib and fedratinib, the first 2 JAK inhibitor approved, unfortunately do cause cytopenias or lower the red cells or platelets, possibly because of the mechanisms of work. They are significant inhibition of that pathway that is involved in the blood cells production. The contrary to one, pacritinib and momelotinib were approved for patients that would have low counts. Pacritinib, particularly for people that will have low platelets, the specific indication is very low platelets, less than 50,000, and momelotinib for patients having anemia or low hematocrit. And then there's category of patient that would have a minimum or no symptoms and spleen and only present with the cytopenia. They possess the hardest category of people to be treated because although momelotinib could improve the anemia, there are no other drugs that would significantly improve the blood counts to the level we would call hematologic remission. They would mostly allow us to address the symptoms and spleen that unfortunately will ultimately emerge or worsen in people suffering cytopenic myelofibrosis. So I will encourage any patient that needs therapy for myelofibrosis, because disease is so rare, to seek experts' opinion at a qualified center across the United States or the globe, to basically ask for a better or more appropriate frontline therapies, except for standardly approved single agents medications, because there are ongoing clinical trials or efforts to combine these 4 approved or even novel agents in the same class to give even newly diagnosed patient-needed therapies. And definitely was emphasized to do the same for therapy that is failing or people needed change, because in the second-line setting, that means after the failure of the first JAK inhibitor, the current success is not really that ideal, and we would like to use a combination strategies in this specific field to improve the outcome and extend the benefits for these patients. One latest category of these diseases represents its acceleration to acute leukemia or accelerated blastic phase. That is unfortunately a black box for these patients currently, where even we have not been able to achieve significant milestones and improve the outcome of these patients. So if there is an increased blasts, which is an indication of disease accelerating, I will highly encourage to definitely seek an opinion, what to do best, how to address this, because in that situation, allogeneic stem cell transplantation is the only cure or only option to prolong survival of these patients. And it could be done only in a certain setting. And there are a lot of different indications or contraindications when not to proceed or to proceed. Therefore, having an expert's opinion or at least a consultation is very important.